So my name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And this evening's Learn and Share conference call is on management of status epilepticus. And we're very pleased to have with us Dr. Donald Phillips, who's a pediatric epileptologist at Beaumont Neurosciences, and also Dr. Nikesh Ardeshna, who's an adult epileptologist at Beaumont Neurosciences. So welcome, both of you. Can each of you start by giving us a brief summary of your clinical and research interests and your experience with this topic?
Okay, I guess I'll go first. It's Nikesh Ardeshna, and thank you, Russ, for having us. So I am actually an adult epileptologist. I spend most of my days either reading EEGs or seeing adult patients with various types of epilepsy. Most of our cases that we see for status epilepticus, not that we want to see those a lot, but they do happen, are seen on the inpatient side in the hospital. From an interest standpoint, my interest is actually seniors in epilepsy and also government advocacy for epilepsy patients. So I work with Congress and Senate trying to ensure resources for epilepsy patients.
Great, thanks. Dr. Phillips?
And hi, this is Don. Yep, this is Don Phillips. I'm a pediatric epileptologist at Beaumont Children's. I spend my days very similarly, reading EEGs, taking care of newborns and children with refractory epilepsy. I also direct our tuberous sclerosis clinic, and so I see patients with tuberous sclerosis of all ages. I did my training at UCLA, including my epilepsy fellowship there. My research interests are both in tuberous sclerosis and broadly in the idea of cognition in epilepsy, including ESES, which I think we'll talk about later tonight.
Great, thanks. All right, so status epilepticus can be divided into two major categories, convulsive and non-convulsive. And while they both refer to prolonged or repetitive seizure activity, the symptoms, risks, and management of each type are different. So with this in mind, we'll talk about them separately for the most part. Let's start by discussing convulsive status epilepticus. Can you define this and talk a bit about the epidemiology and the prevalence and who it occurs in and that type of thing?
So I'll speak to from the adult side of it. Don will, I'm sure, have more highlights from the pediatric side. In this sense, convulsive status epilepticus, it is a risk for anyone technically who has a diagnosis of epilepsy. It can also be, in some cases, the first presentation of someone with new seizures. I don't have distinct figures I can give you in terms of percentages of incidences of it, but it is considered, as Russ mentioned, it is a medical emergency. By definition, the numbers are getting they're getting even more narrowed. Years ago, they would say that status epilepticus, which is continuous seizures, is 30 minutes or more of seizures. Now it's basically down to 5 minutes or less. And the reason it's, from our standpoint, and I'm sure from the pediatric standpoint the same, it is a medical emergency because, number one, if you don't treat it soon enough, the seizures can continue, which in turn leads to other consequences, but I know we'll talk about that later. And number two is the sooner that you stop it, the quicker you diagnose it, the easier it is to treat it. So the shorter period to stop it. And it is, as we said, for neurologists and epilepsy specialists, one of the major medical emergencies that we see.
Okay, great. And Dr. Phillips, Did you want to add something?
Sure. From the pediatric standpoint, it's our most common pediatric neurological emergency. Convulsive status epilepticus simply meaning that there's a motor component to the seizure, and I agree with Dr. Ardeshna that 5 minutes or more we consider status epilepticus. Used to be 30, and we'll talk about some of the physiology that sets those two numbers at 5 and 30 minutes. In the general pediatric population, you're talking about 20 per 100,000 children. So it's something that we see, and at big hospitals we see pretty commonly. We differentiate in the pediatric population between status epilepticus in the patient with known epilepsy versus without. Epilepticus can be from an acute neurologic cause, and often is a brain infection or inflammation, something like that. That can theoretically happen in anyone. In our population with known epilepsy, about 10% of our pediatric patients with known epilepsy manifest with status epilepticus at least once in their lifetime. So it's something that we again see commonly. The most common situation in pediatrics that we see status epilepticus is in febrile seizure, febrile status epilepticus, which we can talk about later as well.
Okay. Is there any difference in terms of age? Is it more likely to occur in any particular age group, or is it fairly even across age groups?
From the adult side, it's pretty even. I mean, in the adult spectrum, but I will agree. Yeah, Dr. Phillips is correct as well that if there is it depends on if there is a cause to it, such as in the adult side, we would often see, God forbid, head trauma or a stroke or something. So the age, for example, the cause is also reminiscent of the risk. So strokes are higher in the elderly population. Head injuries, we see them all the way from age 18 upwards.
Okay.
Yeah, and in the pediatric population, Dr. Ardeshna mentioned the elderly population as status being more common, and really it's all often defined as something that's particularly common in the extremes of age, in infancy and in the elderly population. We see it a lot in our neonatal ICU, and so I would say it's more common in neonates than in older children.
Right, which kind of is in line with the febrile seizures being one of the most common situations where people would present with that. So, okay, so what are the risks associated with convulsive status epilepticus, and why is it considered a medical emergency?
So from the adult standpoint, the risks, consequences of a convulsive status epilepticus can be anywhere from, and I'll just sort of generalize it, there's a small possibility of sudden death, consequences, and also consequences of repeated seizures, so aspiration, difficulty breathing, injuries from a seizure if this was to occur, let's say, not in a hospital setting like a physical injury. And Russ, sorry, can you repeat the second part of that question?
Just in general, why is it considered a medical emergency?
So medical emergency in the sense that, and from the simplistic standpoint, that yes, theoretically continued seizures, and not even theoretically, it's been proven, can cause brain damage. So you want to treat it as an emergency because, number one, the sooner you treat it, the higher the likelihood of you stopping it rather than a delay. And that, in turn, lessens the likelihood of subsequent potential consequences of this many back-to-back seizures, such as injury, aspiration, memory loss, cognitive issues, paralysis. That's just a partial listing.
Yeah, very similar from the pediatric sense. So the risks associated, one could think of in terms of kind of acute or chronic, and in terms of related to the underlying cause. So acutely, like any other medical emergency, we worry about our airway, our breathing, and our circulation. And often we treat status epilepticus first in an ER setting, and we have to make sure that the patient is stable with our ABCs, and sometimes they're not, and we need to address those first, and just like any other medical emergency. And then, like Dr. Ardeshna said, the risks of damage to the brain and the risks of making future seizures more likely, or actually leading to an increased risk of epilepsy in the setting of something like febrile seizure. And then because status epilepticus may be due to a different underlying medical cause, like meningitis, encephalitis, something like that, there are risks associated with those potential causes as well.
Okay. And is it true that convulsive status epilepticus associated with epilepsy has a lower risk of death than convulsive status epilepticus in the broader population because of those other underlying conditions that may be causing it?
From the adult side, I don't think we have definitive evidence of that. And I may be a little, because there's facts and the numbers change over, there's new numbers coming out all the time. Mm-hmm. But I think, to echo Dr. Phillips' point too, especially in the adult population, even though we've highlighted, as you mentioned, Russ, these possible consequences and why it is an emergency, but whatever that underlying cause often is, sometimes could be the bigger problem, or simultaneously, like for the adult side, it's the stroke that often is the big issue, or for that matter, someone who's had a fall or a brain bleed. So in essence, here, as epileptologists, Dr. Phillips and I are sitting there focused on the seizures, but we're also looking for the cause, and there's a team of other people who are co-managing, because that cause is equally as important. Until that cause is taken care of, we don't have the optimal outcome with the seizures.
Yeah, and just to quickly add, in broad strokes, a patient with epilepsy may be presenting in status epilepticus may otherwise be healthy, whereas someone from the general population who's suffered some sort of insult, infection, manifesting as status epilepticus may have something else going on. But so in general, I think that statement, has some truth to it, but I will add a little bit of gray by saying that it does also depend upon the underlying epilepsy that we're talking about.
Sure. Okay. So what do we know about the physiological causes and consequences of convulsive status epilepticus?
So from the causes, basically a single seizure is due to an abnormal electrical discharge. And in this case, because we are having back-to-back seizures or continuous seizures, there's a continuity of this abnormal electrical activity, which, as we talked about, could be from just epilepsy itself. It could be something that has triggered this abnormal activity, such as abnormal dying tissue from a stroke, or irritated tissue by a bleed in the brain. And in terms of consequences, there is a lot of it is where the area the seizures begin at and where they sort of migrate to. The simplest way I could put it is the area that the seizures begin at often determines the symptoms the patient has. Just like if they were to have a single seizure, depending on the area, for example, if it involves the speech center, the speech could be affected. But in the case of status epilepticus, because it's back-to-back, the chances of those consequences, such as speech or motor function, being more prolonged or residual are there, hence the reason to treat it more quickly than a single seizure.
Yeah, and just piggybacking on that, so causes and consequences, most seizures are relatively short. There's papers saying that the average primary generalized seizure lasts 60 seconds and, focal seizure with secondary generalization 90. I think that's maybe a little short in some of our pediatric population, but most of them stop before 5 minutes. And so when we consider physiological cause specifically of status epilepticus, we think of changes that happen in the brain that alter that fundamental balance between excitation and inhibition in the brain. So, and that's why these numbers, this 5 minutes and 30 minutes, is important. At about 5 minutes, our data show that balance starts to shift. Mechanisms that would normally shut down a seizure, that inhibitory side of that equation, lessen. Those receptors become internalized into the cells, and mechanisms that promote seizure continuation, the excitatory side, they get pushed out into the surface of cells in greater numbers. And so in a way, at about that 5 minute point, seizures have a higher chance of becoming self-perpetuating. And then as the consequences, potential consequences, Dr. Ardeshna went over very well, include damage to the brain and increased risk of further seizure or epilepsy in the future. And a lot of our data for those changes occurred about the 30-minute mark. And so that's why those two numbers, 5 and 30, keep coming up in the status epilepticus literature.
I'll add one more thing to that is just, in fact, we're focused on the brain, but of course, if the brain is not working, the rest of the body, with this many back-to-back seizures in an adult child as well, at that point, the consequences affect other organ systems as well. That 3 to 5 minute mark is where we often, from the adult side, we often find, or papers have shown that, oxygen saturation is reduced significantly, as well as oxygen delivery, not just to the brain, but to other organs.
Right, and that's exactly what I was going to ask, is other physical consequences beyond the brain. So,
yeah, it could be, and I'll let Dr. Phillips chime in too, but theoretically any organ could be affected. Initially the ones we always worry about, besides the first ones, are the heart, the lungs, kidneys, and liver.
Are there specific triggers for convulsive status epilepticus that people with epilepsy can try to avoid? Obviously, there's triggers for any seizure or any type of seizure for someone with epilepsy. There's the standard ones, but are there particular triggers that are more likely to result in status epilepticus?
Dr. Phillips, would you like to go ahead on this?
Our biggest, yeah, sure. The biggest single trigger, at least in the pediatric population, is underdosed or missing seizure medication. Up to 40% on one paper I found earlier today of patients, known epilepsy patients presenting with status epilepticus, were patients who had missed their medication. Other potential triggers, alcohol use, sleep deprivation, these sorts of things that are seizure triggers in general can also go on to trigger status epilepticus. In the pediatric population, because we deal with a fair amount of genetic epilepsies as well, it's important to know the underlying cause of the epilepsy, because there are some epilepsy syndromes that are made worse by the wrong medication, and that can precipitate or increase the risk of status epilepticus as well.
And I would agree from the adult side. Same thing. 40. In fact, ours are exactly that 40% number is missed medications, and again, the misses or not consistently taking medications for that matter. So if it's off schedule, the other precipitators again go back to the cause issue. For somebody who, let's say somebody has epilepsy and they are taking their meds, of course, if they're not taking them right, that's one risk right there. But number two is infection or anything that lowers the seizure threshold and makes a higher likelihood for it to occur. On the adult side, I'm hoping we don't see it on the pediatric side. The alcohol and drug use is always an issue, and that, just for information's sake, that includes not just intoxication with alcohol, but also withdrawal from alcohol.
Right. Okay. So what are the key factors that influence the outcome of convulsive status epilepticus?
For our side, one of the biggest factors is timing. You've already said it a couple of times. The time to treatment and sort of getting on top of that cascade away from inhibition and towards excitation, getting medication in to stop the seizures is one of the most, if not the most important key factors in influencing the outcome. Early treatment and cessation of the seizure. Underlying cause plays a role as well. If there is, for example, autoimmune encephalitis causing it or something, those are usually much more difficult to treat than other causes. So underlying cause and early treatment.
And from the adult side, exactly the same as well. Timing, again, the early treatment, the underlying cause. There are certain types, just from the adult side, and I think we see it on the pediatric side as well. There are certain things like, for example, I would say, at least this week we've already seen two, where the status epilepticus was perpetuated by someone having a heart attack or a myocardial infarction. So it's the low oxygen that's the cause on that one, and that in turn is already one major factor in terms of, aside from time, that etiology or the cause is one major factor in terms of outcome.
Right. Okay, so we've talked about causes and consequences. Let's talk about management. So convulsive status epilepticus can be managed in a few different settings: in the community, which could be the school or the home, in an ambulance, and in the emergency department, and then also in the intensive care unit. So this evening we'll focus mostly on the community setting, but can you spend a few minutes discussing the various management protocols used by paramedics, emergency physicians, and neurointensivists?
I can start here. So I think that the most important single recommendation that comes from any study or updated set of guidelines that you look at is that a plan should be in place. And I know that sounds pretty elementary, but when anyone who's witnessed a seizure in their lifetime, no matter how many you treat, if you're in that moment, it can be scary, and it is very helpful to have an algorithm, a protocol to work off of. And studies have conclusively shown that having one in place decreases the time lapse between presentation and treatment and gets the right treatment in to the patient to stop the seizure more quickly. Most hospitals will work off of the International League Against Epilepsy's 2016 guidelines. Those are the most up-to-date. And briefly, this is in an emergency room, this is in an intensive care unit, this is in the ambulance rig as well. The first thing is assessing safety and attending to those, that airway, breathing, and circulation. Quickly reversing any potential exacerbating factors like low blood sugar. And then the first line of therapy in any setting for status epilepticus is usually a benzodiazepine, and I know we'll kind of break down those in particular. If you have IV access, we give that IV. If not, there are other routes. And then after that, there's a cascade of seizure medications and sedating medications one uses to stop the seizures.
And from our standpoint, also the same. Just the two things I'll piggyback on that with are, from the years of, I think, when Dr. Phillips and myself were in training even, they've become, again, knowing that this is a medical emergency, doctors have become much more aggressive in terms of treating this, and we try to convey that to the emergency response personnel as well. That cascade of medications that Dr. Phillips referred to, I remember in the past we would go through, 2 or 3 medications before a sedative medication. That's no longer the case because, again, the time issue is important. And to your question about, in the community setting, I know we'll have a chance to talk about specific agents, but clearly the first step is, again, always, whether it's school, home, is airway, breathing, and circulation. And what can be done in some of those settings is, of course, because we don't have IV access there. But luckily, we have agents that we'll talk about that can be administered in different ways.
Okay. How common is it for status epilepticus to lead to a stay in the ICU? Is that fairly rare that it gets that far, or do you have any breakdown of how often you're able to stop it, in the community versus how often you're able to stop it in an ambulance versus the hospital versus how many get through the ICU, or even rough estimates, or is that fairly uncommon that it gets that far?
I think on our side, with our patients with known epilepsy, we try to do a comprehensive job preparing potential providers at all levels for our patients. So parents and schools. A lot of our families live in communities where the emergency responders know the family and have great experience with stopping seizures. So I would say that, without having numbers, the majority of our patients who suffer an episode of status epilepticus have the event stopped before they reach the ER or shortly thereafter. It's our policy, if patients come to the hospital, that we observe them when they're admitted in the ICU if they've received sedating medications, to make sure that they're, just to manage airway mostly.
Okay.
For new onset status epilepticus, I think more of them end up in an ICU setting, again, in part to expedite workup, and in part just to be very safe.
And the same from our end. I don't think we have numbers specifically as to, what percentage ends up in the ER, what percentage ends up in a general medical floor or the ICU. But I would say the big factor that would determine whether or not a patient ends up in the ICU is whether or not the airway is affected. That, from the adult side, that's usually the big one.
Okay. So with the introduction of several rescue medications, lay people with some basic training can intervene when a generalized tonic-clonic seizure lasts for 3 to 5 minutes. And doing so will often stop the seizure from becoming status epilepticus. Can you discuss the currently available rescue medications, the circumstances in which they should be used, and the relative benefits, risks, and limitations of them?
I think most of these are common between the adult and the pediatric side, if not all. So I'll let Dr. Phillips go first, and then I'll kind of add in. Is that okay with you, Dr. Phillips?
Yeah, absolutely. Most of our patients have either rectal diazepam, the Diastat, or intranasal Versed. We see rapidly dissolving sublingual clonazepam as well. Buccal midazolam is not yet widely used. It's widely used in Europe. Among those choices, a lot of my patients have the Diastat for the simple reason that most patients will never have status epilepticus, and it's a very stable thing to carry around. And I tell my patients just to conceptualize it very much like a bee sting kit, an EpiPen, something you have in case you need it, but you hope you never use. Right. The strengths of the Diastat is its stability. And so it has a nice long shelf life, and it comes preloaded with the exact amount of medication one needs. And with some training, as you said, it's pretty straightforward to administer. The downsides are the route, especially for our older kids. It can be, socially untenable if they need it. The rectal vault can be a depot for that medication to sit in case multiple doses are needed, and so there can be some more lasting sedation with the diazepam. I like intranasal Versed for patients who may use it more often. It has a couple more steps to it. It comes in a vial. It needs to be drawn up from the vial with a syringe and needle discarded. An atomizer is put on the syringe, and half of the dose is administered into each nostril. So there's a couple extra steps. That being said, it works very well. It's socially easier to deploy. And with some training, people become very proficient with it. I have some bias against oral clonazepam for a couple of reasons. The first is in a convulsive seizure, there's often, the patient often bites down, and you can risk your finger in that setting, administering the medication. Secondly, the mouth it's a moving target. It's hard to get the medication in there. Some of the medication will dissolve in saliva and go down the gut tube into the stomach, and that then takes a while to be absorbed. And so among the three routes, I prefer either the Diastat or the intranasal Versed.
Okay. And from the adult side, it's interesting because sometimes, not sometimes, but a lot of our pediatric patients eventually get transitioned to the adult side. And I can tell you, as an adult epileptologist, I appreciate when someone comes in and, there's like, oh, we know about Diastat, we've been trained because we've been used to this for years. So that's always one plus. I'd have to agree with my colleague that, if I had to pick on my choice, I would say either the intranasal Versed or the Diastat. Yes, for adults, even sometimes just like the kids who are a little older, or the teenagers and stuff, the route of administration rectally is not the most optimal from a social standpoint. But again, when you have limited options as a whole, compared to the amount of medications that Dr. Phillips and I have available for just treating seizures, if I want to use that in a generic sense, what we have for emergencies is better than what we had 10 years ago, but still pretty limited. And the other thing is that even with someone who is if they haven't regained consciousness between seizures, giving them an oral pill, number one, they're not safe to swallow, and number two, even if we think they swallowed it, they may not have. And it takes too long, even if it is swallowed, to get through the GI system.
Okay. And in terms of buccal administration, like between the cheek and gum, either a liquid form or the rapidly dissolving wafers, is that, obviously oral is the least preferred of the three treatment routes, but is that an option because it doesn't have to be swallowed or doesn't have to be put under the tongue, but putting it between the cheek and gum, is that something that is ever used or that you've ever, and if so, what are the pluses and minuses of that?
At least from the adult side, we don't use it as much. I think, in a sense, some of it is just it's coming around to it. The Europeans they've been using it more than we have. The wafer, the advantage to the wafer is, again, it's a quick dissolve. But then the question also that sometimes we ask is, does it really have as much benefit as a Diastat or an intranasal Versed?
Sure.
So it's certainly an option out there. I think the other factor from the adult side that would, and I'm going to guess it's common to the pediatric side, is really how many seizures have occurred, because sometimes at that point, or how, I was going to use the word how conscious someone is, but how alert they are in between, which might determine your choice.
Right.
So, and some of it is regional preference. A lot of it's regional availability. The buccal midazolam used in Europe has been shown in studies to be equal, if not superior, in efficacy in how it works to the rectal diazepam, the Diastat. It's difficult for us to get that formulation. They'll, for their non-IV access in Europe, they use that over Diastat. For all of our protocols here from any hospital in which I've ever worked in the national guidelines that I see for non-IV access emergency, all of the societies recommend rectal diazepam or intranasal midazolam, not a buccal or sublingual administration. The wafer does work and does dissolve. I'm not convinced it does so as quickly, and like I said, I'm also not convinced how much of it doesn't run down the throat ultimately and become in the short term useless right. Until the medication is absorbed in the GI tract.
Right. Okay, great. So in the school setting, it's common for non-medical staff to be reluctant to administer rescue medications. So how can parents help school staff to overcome this reluctance and appropriately provide the care that their student needs?
Sure. So, the one thing is that, 1 in 26 have been touched by epilepsy. And so for parents, your child with epilepsy is probably not the only one in the school. And a lot of times the schools are more comfortable than we know. But in any setting, we do a couple of things. The first is we do a seizure action plan for all of our kids. Some schools and school districts have their own. Those are ones that are usually more sort of turned on to some of the issues. Epilepsy Foundation also has a form that we use for lots of our patients, and so that gives schools and school nurses and administrators sort of a brief history of the child, step-by-step instructions for any seizure and what constitutes a seizure emergency, what to do in a seizure emergency. The other thing that we do is our nurses go out to the schools if we think it would be helpful and train who's ever interested in using the device.
Great, and we certainly do that as well, so that's great to know that that's a resource available to your patients and families as well. Okay, so typically 911 is called when rescue medication is administered. Can you explain why this is the case and whether there should be exceptions to this practice?
Yeah, so for our side, there's a few issues. Number one, a lot of the patients and the parents who end up using the rescue medication, it's their first time doing so. And so there is, always the possibility of, some mistake with administration, although we make sure to the best of our ability that our parents, are comfortable with the procedure. Number two, and I think more importantly, the medication may not work. With administration, and the rigs, the ambulance has more potent medication available than the Diastat or even the intranasal Versed or midazolam. Thirdly, any benzodiazepine administered in a dose sufficient to stop a seizure can have side effects, including potentially respiratory depression and certainly sedation. And so, at least for the first time, we like to make sure that there is emergency responders available if the patient needs them. Unfortunately, we do have a subpopulation of patients who do periodically require rescue medication. We do our best to get their seizure treatment under control so that never happens. But in parents who, and these are mostly for kids who use medications for seizure clusters as opposed to prolonged seizures, there are instances on a case-by-case basis where it's not necessarily necessary to call 911.
So is that?
But we do our best to.
Essentially, if there's a fairly well-established pattern, and it tends to they tend to respond the same way each time it's administered, then you can, in those circumstances, if they're likely to use it frequently, you may consider changing that so they don't have to call 911.
That's right. Yep.
Okay.
And I'll just add to that, the other reason, as we said, we focused on number of seizures and status epilepticus, but I often tell all my patients is if one is status, but if the patient is obviously severely injured because of let's say the first or the cluster of seizures, they fall onto something, that's of course the ultimate reason, equally as important to call 911. And from the adult side, there is always that, as Dr. Phillips mentioned, similar to the pediatric side, the first time a rescue medicine is used, even though technically it is a rescue medicine, there's also that apprehension that, yes, I think I administered it right, but I just want to be sure. It's the initial panic factor. And I think that's it. We see some cases where 911 is called, and those are things that can't be avoided. That's also human nature.
Right. Okay. And is there a way where if 911 is called and then when they arrive, it's very clear that that there are no respiratory issues and the seizure has stopped? Is there a way to send the ambulance home without having to admit them or send them to the hospital, or how do you, and can you incorporate those types of instructions into seizure response plans?
From our side on that one, you can, but I would say every seizure response plan to a certain extent is also custom tailored to the patient. In the adult side, and I'm going to say this because some adults will be quite adamant that they do not want to go to the hospital if they are better once the rig arrives. I think theoretically, yes, you could say that, but again, you also have to realize from the ambulance personnel's perspective as well, they may still encourage it just to, for lack of a better term, get checked out because they don't know the whole history. And the other issue would also be where the seizure has occurred, because I know from the adult side, I've got some patients where they've had one seizure or more in the workplace, and despite what my patient wanted, the workplace demands that they go to the ER to get checked out.
Right.
Yeah, I mean, I'd say that when in doubt, it's worth the ride to the hospital just to be safe. However, if the providers assess our patients coming back to their normal baseline, parents have sort of been there, done that, then there are instances where the patient does not need to be transported to the hospital.
Okay. Are there risks associated with using rescue medications too often? And are there any guidelines regarding how frequently rescue medications should be used?
So yeah, we've touched on some of the risks already, namely sedation, respiratory depression. There are guidelines, and we try to write them quite explicitly with the rescue, when the rescue can be repeated, how often it can be used. And so that should appear on every prescription written for rescue medication. Package insert for Diastat, for example, can be repeated once in 4 to 12 hours, and not more than 5 days in a month, I believe, is the recommendation. There are certain specific clinical situations where, we know the patient and we may alter that, but there are definite limitations, which is why care does have to be escalated sometimes where you need to use something different.
Okay.
And I'll concur with that the biggest the biggest thing is, and in any of the package inserts that the callers may have seen, that's the biggest thing is the sedation, drowsiness, or respiratory depression. And in terms of, the question I always ask is when my patient then follows up, if I've, in that 3-month interval since I've seen them, or 6 months, if there's been a markedly increased usage of rescue medicine, that basically is, for physicians, it should give us a clue that maybe it's time that we've got to adjust the rest of the anti-epileptic regimen. Or, of course, the other question is, why is this occurring? Do we need to go back and investigate why has the seizure frequency changed?
Right. Okay, and briefly, can you talk about the differences in terms of risks and management between status epilepticus involving one prolonged seizure, status epilepticus involving one seizure after another without regaining consciousness in between, and then acute repetitive seizures, which where you may have consciousness return between seizures? Is there a significant difference in terms of risks and how they're managed?
From the adult side, there is differences in terms of, and I guess the best way I can phrase it is escalation. Like Russ, I think you mentioned a single seizure versus some back-to-back without gaining consciousness. I don't think I can't say that there's a definite algorithm for each one. Really, it's how many and what the circumstances are in between. I will say, though, that with acute repetitive seizures, which I believe you alluded to, say someone's having say they've had 20 focal seizures, that's a little different. At that point, we don't necessarily go aggressive. We actually don't go. We recommend not going aggressively for intubation and that type of stuff. Because, again, if it's a cluster and the patient is used to that, question is, can we optimize their treatment better?
Okay. Yeah, agreed. We see the prolonged single seizure and the cluster of seizures without returning back to baseline treat pretty similarly. That cluster without return to baseline can easily escalate to a prolonged seizure. The acute repetitive seizures, that's a common occurrence in pediatrics. This is where a lot of our families lean on our office, on the on-call physician, et cetera, to perhaps make adjustments in the seizure medication as opposed to a rescue medication, or do something to temporize that. We spend a lot of time looking for underlying cause in acute repetitive seizures as well. Is there something triggering this increase? But that's treated a little bit differently than the first two.
Right. And just one more thing in terms of recognition. I've read that that sometimes as convulsive status epilepticus continues for a long enough time, that the actual convulsive movements can become so subtle as to not be detected by a layperson. Is that ever an issue that people encounter, that they maybe administer a medication and they think that it's worked, but in fact it's just that the status is continuing, but the amplitude or the severity of the convulsions is reduced? Is that something that occurs?
I would say to a certain extent, yes, it could occur that way, although my caveat would be that, let's say the convulsions have stopped, and if it was my family member and they're still not returning back to their baseline, my first response would be, then I've got an emergency here.
Right.
What I believe, from the adult side, and this is it's not new, but it is certainly important. The recognition standpoint, yes, theoretically, you could have lower amplitude motor movements, but also you could have basically no motor movements. About 30% of patients who are in convulsive status epilepticus can go into non-convulsive status epilepticus, and they can also flip back and forth. If that does occur, then clearly the sign is that this person needs to be treated much more aggressively. And again, going back to the idea of a medical emergency.
Okay.
Yeah, and we'll talk, about non-convulsive status epilepticus and the case for EEG in these patients as well to detect that continued seizure. You can have what we call electroclinical decoupling or dissociation, where the brain continues to have seizures and you don't see any physical manifestations, or, as you said, Russ, very subtle clinical manifestations. A specific age group, we see it in all age groups, but it's particularly common in neonates. And there's physiology that we won't go into why that is, but up to 2/3 of neonatal seizures can clinically stop and continue on the EEG alone with partial treatment.
Right, and I guess this all supports the idea of calling 911 when rescue medication is administered.
Right.
Right. Okay, so that's a good segue into non-convulsive status epilepticus. Whereas convulsive status epilepticus is fairly straightforward to recognize, non-convulsive status epilepticus can much more easily be missed or confused with other conditions. So can you talk about the different types of non-convulsive status epilepticus and how to distinguish them from other conditions and what they look like in general?
I can start from the pediatric side. I would break down non-convulsive status epilepticus into a couple different groups. Number one, is it a manifestation of a known epilepsy? So simple partial status epilepticus, complex partial status epilepticus, absence status epilepticus. Is this a manifestation of the patient's normal seizure? Group number two, like we alluded to, is this a patient who had convulsive status epilepticus and the convulsions have stopped but the seizure continues? Or number three, is this a critically ill patient, which Dr. Ardeshna may address in more detail. It's something we often see in the adult population. In the pediatric population, the vast majority of non-convulsive status epilepticus are in patients with known epilepsy. And a couple particular things we see status absence, which is a kind of a continuous absence seizure. We see myoclonic status epilepticus, which are quick jerks that persist. Both of those lasting longer than 10 minutes or more, as opposed to the 5-minute mark for convulsive status epilepticus. And epilepsy partialis continua, EPC, is a very specialized focal epilepsy, which is kind of a continuous motor seizure, and there's some specific epilepsy syndromes that may be associated with. Differentiating from other conditions can be difficult. One of the clues we have in our group, in our patient population, is the fact that a patient is a patient with known epilepsy. And there's a list of kind of mimics that one can go through, and I don't know if you want to talk specifically about some of them or not, but it can be difficult and sometimes often requires a trained eye and can require EEG as well.
Okay. And the same from the adult side. It is, as Dr. Phillips said, that from the adult side, the two divisions. We can actually subclassify non-convulsive status epilepticus into essentially the same types: simple partial or absence or complex partial. But the way I tend to put it under an umbrella initially is it a critically ill patient, something that we have to consider but would not necessarily expect first, or is it a patient who has known epilepsy and hence they came in status, or let's say they develop status epilepticus and hence the odds of them being in non-convulsive status are much higher. And the last thing I'll add on there is part of, a lot of what Dr. Phillips and I do is we actually try to, as much as possible, even educate our colleagues, providers of other specialties, because the recognition factor, as you mentioned, Russ, not only is it difficult on the outside, it is even difficult for physicians who are not specialized in this field. And theoretically, the only way to officially detect it and diagnose it is continuous EEG.
Okay. And you don't have to go into a lot of detail here, but can you just talk about some of the other conditions, just briefly, that it may be confused with, and just to give a sense of how difficult it can be to detect?
Sure. So, for example, status absence may be a patient with absence epilepsy who, is having either a continuous absence seizure or several on top of each other, and so their attentional network, what they use in their brain for attention, is hijacked by this seizure and hijacked for some time. They may be partially aware or seem partially aware, may very much look like someone who has just some mild confusion, someone who's moving less than they normally do, or even sitting still. It's like someone who may be catatonic, or you may have a focal sensory seizure that gives tingling in one arm that can be confused with a migraine, for example, that also can have focal or multifocal sensory symptoms. If your focal seizure happens to be in the right parietal lobe, it could look very much like acute psychosis. So it can be very difficult.
And from our side, I would say the magic words, as Dr. Phillips had said, some of the things that kind of mimic it. So a catatonic or a behavioral health catatonia could, patients not moving, they're not responding. There are some types of dementia, again, this is more on the adult side, that we would see this. I've even seen cases where someone has a severe movement disorder, a subtype of Parkinson's, because they are so slow and or unresponsive. People have considered that, consider the possibility of non-convulsive status.
Okay. And what's the range of how long non-convulsive status epilepticus can last if untreated?
From the adult side, I don't think we have a range. What I can say is that the longer the person has been in convulsive status epilepticus, the longer the likelihood, or the higher the likelihood of transferring then to non-convulsive, and a longer likelihood of non-convulsive status.
Okay.
And from our side, there's specific epilepsies that can be highly refractory. We tend to think about things in a little bit longer of a timeline from a non-convulsive versus convulsive standpoint. So like I said, 10 minutes for status absence, but there are non-convulsive seizures that last hours. The epilepsia partialis continua can last days. There are some autoimmune encephalopathies that have frequent or constant seizures that can last for weeks. So obviously we try to make it we do our very best to make it as short as possible, but it can be a much longer timeline than convulsive status epilepticus.
Okay. And how common is non-convulsive status epilepticus? It's certainly not something that people I talk to on the phone mention very often. Is it more common than people think, or is it actually not all that common? And then also, who's most likely to experience it?
So from the adult side, the more likely to experience it would be someone who, first of all, has epilepsy, and from our side, the statistics are about a 30% chance of someone who is in convulsive status epilepticus can go to non-convulsive status epilepticus. But in the intensive care setting, there's a statistic that the number goes between 10 and 20% of patients who are in a coma could have non-convulsive seizures.
Okay. Yeah, I think it's under-recognized still in the critically ill population. That's for sure. In the known epilepsy population, I would say it's on the more uncommon side of things. But in the critically ill population, I think it's under-recognized.
Okay. Well, that's a key distinction there. All right. So are there triggers or risk factors for non-convulsive status epilepticus that can be avoided?
I think the biggest risk factor is convulsive status epilepticus, so that's the one we want to avoid.
Right.
And then for some of our genetic epilepsies, especially avoiding the use of the wrong medication. So if you have an SCN1A mutation, don't use a sodium channel blocker. You have POL-G, don't use Depakote, that sort of thing, things that can exacerbate seizures and cause non-convulsive status epilepticus in specific settings.
And I'll even add to that, just as a quick, and I'm sure Dr. Phillips even sees this, but we get patients who have absence epilepsy, who are, again, the importance of being on the right medication. If they come in on Tegretol or something like that, yes, a small percentage of those can be in non-convulsive status.
Okay. So non-convulsive status epilepticus is maybe not considered as much of a medical emergency in the sense that convulsive status epilepticus is, but prompt medical attention is still needed. Are there risks of not getting prompt treatment for non-convulsive status epilepticus?
I mean, from our standpoint, there's kind of two things to be considered. The first is that in the critically ill population, the non-convulsive status epilepticus in some settings can be thought of as a symptom of what else is going on. So it goes part and parcel with treating that patient, as aggressively and as need be. From the epilepsy side, a prolonged seizure, whether or not that seizure is connected to the outside world, in other words, if it's affecting motor or not, can have the same, and again, this depends on the underlying epilepsy, but in certain circumstances, can have some of the same long-term potential side effects as convulsive status epilepticus. We've all seen, at least anecdotally in our practices, patients who have primary epilepsies, a lesion somewhere in the brain causing an epilepsy, who've had prolonged non-convulsive seizures, who develop secondary epilepsy sources because of those previous long seizures, whether or not they had physical or detected manifestations.
Okay. And so how are the different types of non-convulsive status epilepticus treated? Is it similar to convulsive? Is it, if not, what are some of the differences?
From the adult side, again, we're a little same thing. The timing is there's a little more leeway. That's the 10-minute mark. For us, the 10-minute mark is also the same number. It used to be more in the 30-minute mark for non-convulsive, but I think it's trending down again to 10 now. But the treatment is really, the medication choices depend on the type of non-convulsive status epilepticus, just like the type of convulsive seizure.
Yeah, for the ones that are based in our childhood epilepsy syndromes, you're much less likely to be treating with the benzodiazepine as kind of an urgent treatment, and much more likely to be giving increased doses or doses of the appropriate seizure medication. And most non-convulsive status epilepticus in our known epileptic patients, so status absence, myoclonic status epilepticus, et cetera, do very well with that treatment.
Okay. And is that something that if a child is prone to that, they're like absence status epilepticus or clusters of absence seizures, that's something that will generally be discussed between the epileptologist and the parents in terms of here are the steps of what you should do if you're having clusters of absence seizures.
That's right, and that's something that could also be present on a seizure reaction plan, for example.
Okay. All right, another type of status epilepticus that we just wanted to touch on is something called electrical status epilepticus in sleep, or ESES. And that's a feature of several childhood epilepsies and includes prolonged periods of interictal epileptiform activity during sleep. So again, that's just abnormal epileptiform activity that doesn't necessarily manifest with visible symptoms. And then there's also some level of cognitive regression. Can you talk briefly about the main types of epilepsy that include ESES and some current treatment options?
Absolutely. Yeah, so we conceptualize ESES as sort of a potential and a relatively rare still complication of multiple different epilepsy types. ESES is just the EEG pattern, and we define that as more than 50% of slow wave sleep, so deep sleep, being abnormal, being affected by what you indicated, interictal epileptiform abnormality, so not seizures, just the fingerprint of the underlying epilepsy syndrome. And we were concerned about it because it can have potential cognitive manifestations. The clinical syndromes range from things that are well-defined, like Landau-Kleffner syndrome, which is a specific language regression syndrome, and CSWS, which is kind of a broad developmental regression and delay, to more subtle behavioral and cognitive symptoms, stagnations, or regressions. Some epilepsy types are more likely to manifest as ESES than others. We do see ESES as a potential complication of our what we call benign focal epilepsies of childhood. Things that you may have heard the term Rolandic epilepsy in the past. It's a genetic epilepsy that kids almost universally outgrow, but can be complicated by this ESES pattern, and it kind of lives on a spectrum of, typical versus atypical benign focal epilepsies of childhood. Can also be complications of focal epilepsies from underlying structural abnormalities, and our epileptic encephalopathies are our genetic epilepsies that can affect cognition as well. It's something that can only be detected on EEG, and it's something that if we have, it requires, sort of your doctor to have a suspicion that there may be a cognitive contribution from your epilepsy in order to do the overnight study to look at sleep and to detect it and treat it. Treatment is, we have a couple of options. The three broad categories are seizure medications, high-dose diazepam protocol, and oral corticosteroids, prednisone. And which one we use and how we use it sort of depends on the particulars of each case. I tend towards the latter two, either the diazepam or the prednisone, if there has been a noticeable cognitive stagnation or regression, because those are high-potency, short-term treatments that can reverse that process if it's caught in time.
Okay. And how long typically is that used, and if it's used successfully, how does that affect prognosis?
Sure, absolutely. Prognosis depends in part, depends in part on the underlying epilepsy syndrome. Sort of working with our benign childhood epilepsies, or benign focal childhood epilepsies that overall have the best outcome, there we can often sort of reverse the changes that have occurred. I've had patients with Landau-Kleffner syndrome, which is again that very pronounced language regression, who we treat with our diazepam and they talk again and they essentially normalize or get back on a normal developmental curve. The treatment, or the initial treatment with a high-dose diazepam is usually about 4 weeks, 4 to 6 weeks, and then we decrease the dose and slowly taper off depending upon the patient response on the EEG and clinically. Prednisone is about the same initial course and can continue up to 6 months depending on clinical response. Average time on that is between 3 and 6 months. We don't like to use steroids long term. Seizure medications tend to be kind of the same durations as one would use for seizure itself, and often used in combination with seizure. So, we like to see seizure freedom for 2 years before we stop seizure medication, so it's usually a longer course than the first 2.
Okay, great. So before we open it up for discussion, did either of you have any closing thoughts or words of advice you wanted to share?
Not from my standpoint.
I think the only thing that didn't come up that's kind of key in our epidemiology, kind of understanding who has status, is that the chances of a patient who's had status in the past re-presenting with status epilepticus is much higher than the population with epilepsy without status epilepticus. So once your patient or child has had it once, we need to make sure that they're on a very good rescue regimen just in case. Okay,
great. I also wanted to remind listeners that, excuse me, that you can contact Epilepsy Foundation of Michigan at 1-800-377-6226 or visit our website at epilepsymichigan.org for more information on this and other epilepsy-related topics. So let's go ahead and open it up for questions.
I have a question.
Okay, go ahead.
Hi, my name is Kimberly, and I have the PNES seizures, and I just don't know if that is anything to do with the non-convulsive or status epilepticus. Does that involve with those or no?
Or maybe a good question is there ever misdiagnosis between psychogenic non-epileptic seizures and non-convulsive status epilepticus?
Yes, there could be a misdiagnosis between those two, or for that matter, the PNEE and a convulsive status epilepticus. The best way I could summarize it is, do we, as physicians, do we see that? I know on the adult side, often as a misdiagnosis, and yes, non-epileptic seizures could occur back to back. It is not, though, treated in the same way, and it should not be like an intubation algorithm or something like that convulsive or non-convulsive status is.
So I'm just curious, can I've had seizures where 3 hours straight, and I even go out sometimes of it, and then they put a fist in my chest to revive me. So I'm just curious if that, I don't know how to ask this, if that is happening.
So I think there's a couple of ways to dissect the question. I think the first may be a concern that is your brain susceptible to the same potential damage as if it were a 3-hour convulsive seizure. And thankfully,
yeah, get brain damage. That's a good thing. Yes, that's what I want to know.
Sure. So in general, the same sort of explosive reactions that are happening in the brain in a continued epileptic seizure are not happening in a non-epileptic seizure, and so the likelihood of damage from a non-epileptic seizure is far, far, far less than in an epileptic seizure, which is universally good news. The biggest risk in a non-epileptic seizure, especially if it's a prolonged or repeated one, is treating it with medication that is used to stop convulsive status epilepticus, because then your treatment may be complicated by things that, like Dr. Ardeshna was saying, like intubation and sedation, that otherwise wouldn't need to occur. And so making the distinction between the two for people who are meeting you for the first time, especially in the healthcare setting, is essential.
That's a really good point, yeah. Okay, other questions?
Isn't Ativan a good medication for something like that? Because I know I take Ativan, and I know by going through some seizures and everything, take a couple of Ativan, it calms me down.
So Ativan can be used. Some patients do use it as part of their daily regimen to control their seizures. I know for most adult epileptologists, it is not the first go-to medication. They would try what I refer to as more typical medications first, such as Keppra or Dilantin or something, or
both. I take both of them.
But Ativan can be used in the emergency situation, again, similar to what Dr. Phillips and I talked about earlier, in terms of, oral administration or IV administration. Yes, to your point also, most people will say that it will have a calming effect. I think from a safety standpoint is if you end up using it more than anticipated or the use is increasing, we go back again to the fact that it's time that the original regimen should be looked at for an adjustment.
Okay, and other questions?
My name is Maggie, and I have had epilepsy for 60 years. Yes, I'm that old. And I have never had I've never had status epilepticus, and I'm thankful for that. But I'm wondering, is there a likelihood that I could, just out of the blue?
There is always a likelihood. There is always a small likelihood, theoretically. But one of the best things that you just said is you've had it for 60-odd years and you haven't. In fact, one of the things that we as physicians, we're taught and we're also advocate for is to minimize your risk of this. Even for, you don't want to even have a one-time occurrence. The most important thing is an optimum degree of seizure control and compliance with medication, which it sounds like from what you're telling me, you got.
I've got.
Great.
Tell him, Doctor. Check.
Thank you.
Doctor.
Someone else was trying to ask a question as well. Who's that?
Yes, hi. This is Dan and Jess Armstrong. We have a 9-year-old daughter who was diagnosed with generalized idiopathic epilepsy about a year and a half ago, and since the day that she had her grand mal and her first, what I now recognize as a cluster absence episode that preceded that, she has absenced every day since then, and cluster absence episodes are routine for her. I'm wondering, what's the difference? You used both terms. What's the difference between absence clusters and absence staticus epilepticus?
Good question.
Yeah, it's difficult sometimes because in childhood absence epilepsy, which is the most common epilepsy that manifests with absence seizures, children can have 100 or more absence seizures a day, and I often tell my parents, if you're seeing 20, they're having 100 thing. It could be, as you know by now, they're brief, they're short, and if you look away, you miss it. And so the distinction would be that sort of space in between, meaning that she spends most of her day, even though she has lots and lots of absence seizures in clusters, she spends most of her day normal without seizure. If she had a sustained absence seizure where she ceased to interact or was markedly interacting markedly abnormally with you, it lasted 10 minutes or more, and we couldn't break it, that's when we would call it non-convulsive status epilepticus or absence status. It's usually something that, at least in childhood absence epilepsy, it's rare. It's quite rare. It most commonly manifests when the patient's on the wrong medication, actually.
I think that's the circumstance that our daughter is in, actually. She has and does go through these sustained, markedly can't interact with us. I can see the seizures rolling across her forehead. She's confused. She can't function. She can't follow protocols. And our epileptologist has given us the clonazepam tabs that you mentioned before. We're now trying Onfi as a rescue med for her in those situations. My daughter has failed over 7 medications to this point, AEDs. And I guess I'm wondering a couple of things. Can the AEDs themselves cause absence seizures or this NCSE?
Yeah, notably, sodium channel blockers, as Dr. Ardeshna said earlier, Tegretol, Trileptal, phenytoin, Dilantin, medications like that can exacerbate generalized seizures like absence. Broad-spectrum seizure medications like Onfi are not known to do that. When a patient has something like that looks like an epilepsy that should be pretty straightforward to control, and is refractory, that's certainly a setting for an epileptologist. And in the setting of continued seizures, I would encourage, and I never take issue with my patients seeking a second opinion, just to make sure that everything that should be done has been done and could be done has been done.
And from my standpoint, even if we have adults that are, let's just say that their degree of seizure control is not optimal or the seizure pattern has changed, I too, have sent patients from my own clinic for a second opinion because they need a second look at it from another angle, possibly.
Okay. So, Russ, that EF often provides, referrals or options for patients, right?
Yeah, absolutely. Yep. You can always contact us, and we can let you know all of the different comprehensive epilepsy centers there. And we're very lucky in Michigan that we have several. So a lot of different opinions, and sometimes, again, it's not saying you're, unhappy necessarily with the care that you're getting. It's just getting a different set of eyes on it, and then that often can be the difference. So
yeah, everyone involved is an advocate for your child. Ego has no place in this. So we see a lot of second opinions. There are patients who come to us who seek opinions after us. So as long as our children get better, we're happy.
Right.
And from our standpoint, actually, most of my clinic, I can tell you, was actually third opinions or fourth opinions, and not saying again that one person is going to make the difference, but it is for the standpoint of for the kids, for the adults, because again, some of these are lifetime conditions. Dr. Phillips sees them, I see them later, to get them the best care that they can. Perhaps to look at options that may change over time or that are newly available, and to see that those options have been considered.
We're currently considering, and trying actually, CBD oil therapy for her now. I know that licensed epileptologists in Michigan don't typically offer dosing recommendations on that yet because of the lack of studies done to back it up. But if you're a parent in our situation, looking at the failure rate of the medications that our daughter has been on and the proponents of CBD, it's something to try. Do you have any comments about CBD therapy or CBD oils that you are safely able to make, or no?
My general approach to CBD is that it's a compound that passes into the brain, that interacts with the brain. It's going to, in some settings, have some effect on epilepsy. We have, for the first time ever, positive phase 3 clinical trial results in Dravet syndrome with the CBD that is made by GW Pharmaceuticals. Those data came out in December, I believe. And so, you know, the issue you've pinpointed with other commercial sources of CBD and hemp oil and all of these other things is not only it's becoming less of a data issue and more of a source issue. For instance, when I give something to my patient, I want it to be a safe metered dose, so the same amount every time of a known substance that's been looked at for side effects and safety. And that process is moving forward, but it's not there yet with CBD. And I don't dose it for a couple of reasons. The biggest of which is I don't, you know, for any product available, let's say you get Charlotte's Web, and let's say you get Charlotte's Web every single time, you know, from vial to vial, the amount of the, you know, purported active ingredient may still differ. And so it's, for us, you know, I know when I give 10 milligrams of Onfi, it's 10 milligrams of Onfi every time, and there's safety in that doesn't exist with CBD. Now, I'd like to know that my patients are on it because it interacts with other medications like Onfi, and I also, you know, do EEGs to see the potential benefit of it. If it's working, fantastic. If it's not, it's just like any other medication. You don't want to be on it if it's not doing anything. So we often do EEG to prove or disprove efficacy as well. But yeah, I agree with who you're seeing. We don't opine. We don't recommend specific dosing. And that's the same actually in California. I did all my training in California. You may know that there's incredible interest in California on CBD. All my patients asked about it there, and even there, people aren't making dosing recommendations by and large because of these reasons.
Sure.
Do we have time for one more question from maybe if there's someone who hasn't had a chance to ask a question? Is there anyone who
I have a question.
Yeah, go ahead.
How many years? I have a child with epilepsy. She's been seizure-free for 4 years, from what I know. When do you consider taking them off medication?
The generic answer to the question is 2 years. We have data showing that 2 years can be predictive of long-term seizure freedom. The long answer is it depends on the underlying epilepsy syndrome. A lot of times we use...
Well, she has autism, too. So it's hard to tell if she's having any absent seizures. But the ones that she had were visibly non-convulsive seizures. But she hasn't had anything significant for 4 years, but the doctor seems somewhat apprehensive to take her off still. So I was curious what you would say.
Sure. So EEG can help guide in some of those situations, and sometimes we lean on that. The other thing to know is that the incidence, and I'm sure you know, the incidence of epilepsy is higher in our autistic population than in patients who were completely neurotypical. And so that may, you know, be reflective in your provider's reluctance. But yeah, it really depends on the specific case.
Yeah. And I would just add in there that compared to years ago, I mean, even in my training, we do this much more. That question comes up for adults too. Is now that we have EEG available, we kind of put that into the equation. And it's more widely available as part of a data-driven approach.
Okay. Yeah, all her EEGs always come up normal. So
yeah, that's
even when she was, yeah. So it's just scary as a parent to know what to do, and you know, and you also don't want her on medication if she doesn't need to be. So just kind of in a bad situation, I guess.
Yeah, and in that situation, not knowing the specifics, so this is a general comment. In that situation, we lean on population level data, and those data show that, you know, if you've gone 2 years, you have a fighting shot.
Yeah, and I would concur in the adult realm. It's the same, 2 to 2 years.
But you always wonder, is the medication why she's not having them?
Right.
If you take her off the medication, she can start having them.
my line to my parents is often that everyone deserves a chance to come off medication, and if seizures come back, we know what worked.
Yeah,
right.
True.
Right.
All right, well, thank you.
Okay, in the interest of time, I should wrap it up here, but I thank both of our presenters for a really comprehensive call on a very challenging subject. So I thank you so much. And if people do have any remaining questions, you can certainly call or email me. And I bet you if they're beyond my skill level, I could certainly ask our presenters if they could give their responses via email. So thanks, everyone, and have a great evening.
Thank you for having us.
Thank you.
Thank you.
Thank you.
Thank you.